Hi, today I'm going to talk about hypocortisolism and how often it's a misdiagnosis. This presentation is meant for medical uh, practitioners, irrespective of your specialty. I mean, it is not meant only for endocrinologists. So, the whole idea is to bring out how hypoadrenalism, though it's a very common condition, is missed in clinical practice by a vast majority of doctors because the presentation can be quite challenging. I hope you enjoy this presentation. So around 2 years ago, I was referred this 44-year-old lady by a neurology colleague. She had a history of generalized and easy fatigability and weight loss. She used to have no energy at work, and she was very anemic also, for which they could not find a reason. And but she did not have any diabetes, hypertension, or cardiovascular disease. She'd been admitted twice in the previous 5 years with very low serum sodium. History of hysterectomy was there. The hysterectomy was done for heavy menstrual bleeding. The exact condition on the reason for which we did not know. Subsequently, she had a surgical menopause. So um, you can look at the baseline evaluation for this patient actually. So you look at we did a AM cortisol for this patient. It was 1.4 microgram per deciliter. So this value clinches a diagnosis of adrenal insufficiency. So along with that, we did her thyroid hormone profile T3, T4, TSH. You can see that the T4 and T3 are low, whereas the TSH is normal. This pattern is typical of central adrenal insufficiency. And also, we looked at the fasting glucose, and the patient also had glucose in the hypoglycemic range, though she did not have any acute clinical features of hypoglycemia. So the patient did have a history of anemia, and her hemoglobin was very low. So we started treating the patient, and over the years she has gotten better. So this is her latest. These are her latest values. She actually gained 13 kilogram weight. She is eating much better. Her appetite is normal, and she, her quality of life has improved leaps and bounds. There have been no hospitalizations over the last 2 years. So let me go to our initial treatment. So this is how we started the treatment initially. So we gave the patient around 12.5 milligram of hydrocortisone, and after initiating the patient on hydrocortisone for 1 week, we started the patient on thyroid hormone 25 microgram, gradually increasing the dose. And of course, we treated the patient with iron as well as B12. So this is how we started the patient on treatment around 2 years ago, and she seemed to be doing well. So I'll go into one or two reasons why other doctors probably missed the diagnosis here. What I felt was that the patient had amenorrhea due to surgery, and this kind of masked the probable history of amenorrhea. So, if there is a central hypopituitarism, one of the earliest symptoms tends to be amenorrhea because of hysterectomy. So, this particular symptom was completely masked over. And also, the patient did have comorbidities. She did have anemia, which was not improving very well. And also, probably there was no improvement in anemia because of hypopituitarism. There are several papers over the years which have documented clearly that treatment of thyroid dysfunction and treatment of adrenal insufficiency is critical to restoring hematopoiesis in those who are hypopit. So this is approximately how the patient looked when she first presented to me. So you can see that there's a generalized hair loss or alopecia that the patient had. And also you can see that the patient has an aged appearance. This is not actually the patient that I have examined. It's actually taken from a case report which was published. This is available on the internet in the year 2016. So you can look at the furrowing of the forehead, and the wrinkling that is seen on the face. So this is mainly because of absence of several hormones concurrently. So, and the pale look is because of absence of ACTH, to be specific. So the lack of thyroid hormone, the lack of growth hormone, and the lack of adrenal androgens all together tend to give this appearance. So unless you are attuned to examining the patient and look for this condition specifically, you can easily miss a diagnosis of Sheehan syndrome or central hypopituitarism. So it's one of the conditions which are famously missed often in clinical practice. So, what are the common presentations of adrenal insufficiency at diagnosis? So, there can be severe body aches. So, this is one of the presentations of adrenal insufficiency, and sometimes you can have a low grade fever as well, which goes along with the severe body aches. So, this is because of unfettered cytokine production. So, in our body, the cortisol actually is a hormone which suppresses inflammation. So, there can be some baseline level of inflammation that's happening in the body, and it is through the activation of nuclear factor kappa beta that the inflammatory cytokine production occurs, and this cytokine production causes fever. So a baseline level of cortisol production is actually required to suppress this cytokine production, this inflammation which is happening in the body. So in the absence of or withdrawal of cortisol results in a flu-like symptom. So the patient may have body aches and fever and malaise. You may actually mistake it for that the person is actually having a viral fever. So it's very common. This is typically seen in those who have taken steroids for long duration and they've stopped it abruptly. So there can be a severe loss of appetite also, and there can be hyponatremia. Hyponatremia, especially if it is recurrent, should make you think in terms of central adrenal insufficiency. So those patients who are critically ill and admitted to the hospital and are having hypotension, so you need to think in terms of adrenal insufficiency. Hyperkalemia can be a rare manifestation of adrenal insufficiency. It's mainly seen in primary adrenal insufficiency and not secondary adrenal insufficiency. So these are some of the features of adrenal insufficiency. So in secondary adrenal insufficiency, in addition to these uh, symptoms, we do get recurrent hypoglycemia. So the recurrent hypoglycemia is because of concurrent deficiency in growth hormone and thyroid hormone, also in addition to cortisol hypocortisolemia. There can be a loss of libido, which can be because of the lack of sex hormone production. So, whenever there is hypopituitarism, every hormone in the body is reduced, and that leads to multiple symptoms. So, a person having all these symptoms all rolled into one, you need to think in terms of secondary adrenal insufficiency. So, what are the commonest causes of adrenal insufficiency diagnosed in adults? So, when you look at primary adrenal insufficiency, where the adrenal gland is primarily to be blamed, so the most common cause is granulomatous or infiltrative disease, especially in India. So, we also have autoimmune adrenalitis, which can be, which is world over the commonest cause. In developed countries, autoimmune adrenalitis becomes the number one cause of adrenal insufficiency. Though it's a very rare disease, it's a number one cause of primary adrenal insufficiency. So very often we do bilateral adrenalectomies for Cushing's disease, where we are not able to localize the tumor. So this again is one of the common causes for uh, adrenal insufficiency. Pheochromocytoma, especially if it's bilateral, if we don't do a cortex sparing adrenalectomy, so you end up removing both the adrenal gland. This surgical adrenal removal is one of the important causes of adrenal insufficiency. As you can see, primary adrenal insufficiency is much less common when compared to secondary adrenal insufficiency. We all know that withdrawal of steroid therapy is the number one cause for secondary adrenal insufficiency. So you can have Sheehan syndrome or any critical illness which can cut off the blood supply to the pituitary gland temporarily and cause permanent or irreversible damage to the pituitary gland and result in hypopituitarism. This is one of the causes for secondary adrenal insufficiency. Head trauma, pituitary surgery, and radiotherapy are also important causes for secondary adrenal insufficiency because pituitary tumors are fairly common tumors in the population. So let's look at some physiology so that we understand adrenal insufficiency more comprehensively. So the pituitary gland is the main switch. So the pituitary gland produces ACTH, and ACTH hormone is both trophic for the adrenal gland and it's also necessary for minute to minute release of cortisol. So if the ACTH is withdrawn, the cortisol is withdrawn, but then aldosterone is intact because adrenal gland produces aldosterone not under the influence of ACTH but under the influence of angiotensin 2. So the adrenal production of aldosterone does not depend on ACTH. So aldosterone being more evolutionary conserved molecule, it is required for mineral homeostasis in the body, for retention of sodium in the body. So it's a preserved uh, function and it's not under the control of ACTH. So angiotensin 2 acts on adrenal gland to make the adrenal gland produce aldosterone. So aldosterone production is preserved whenever there is pituitary disease. But whereas when you have adrenal disease, so you have deficiency of cortisol as well as aldosterone. So this distinction is very important to make. So in the presence of hyperkalemia, we always tend to think in terms of primary adrenal insufficiency and not secondary adrenal insufficiency. So now let's come to how to obtain a definitive diagnosis of adrenal insufficiency. So globally, we assume that somebody has adrenal insufficiency if their AM cortisol is below 3 milligram per deciliter. So um, this is well accepted. So we also use another method for diagnosing adrenal insufficiency. We give cosyntropin, 250 microgram cosyntropin, and stimulate the adrenal gland to produce cortisol. If the cortisol production is less than 18 to 20 microgram per deciliter, we consider it adrenal insufficiency. We use ACTH levels to distinguish between primary and secondary adrenal insufficiency. Sometimes you may have a lot of doubt regarding the source of or the cause of adrenal insufficiency. So this graphic clearly shows that ACTH is highly elevated in those who have primary adrenal insufficiency, whereas it's very low in secondary adrenal insufficiency. Typically, a cutoff point of 100 is chosen. So usually those who have primary adrenal insufficiency have ACTH values which are very high. And ACTH assay can be done randomly. Anytime you can do it. If somebody has primary adrenal insufficiency, they will have high ACTH. But if they have secondary adrenal insufficiency, ACTH tends to be below 100. So you can have some bioinactive ACTH also being produced from the pituitary gland. So that could be the reason for the detection of ACTH in the serum. So let's understand the role of ACTH a little better. So ACTH is like the godfather of the adrenal gland. So it not only it does two things. One is that it nourishes the adrenal gland. Uh, it makes the adrenal gland grow, and also it has got a immediate effect of transport of cholesterol into the mitochondria. So you all know that all adrenal hormones are steroid hormones. They are built on a steroid side chain, and steroids come from cholesterol. So basically, the supply of cholesterol into the mitochondria of the adrenal gland is due to the effect of ACTH. So in the absence of ACTH, you are not going to have any steroid hormone production. So if there is an acute ACTH deficiency, also you will not have any cortisol production coming out of the adrenal gland. So ACTH goes in, and then you have adrenal hormones being formed. So with this background in mind, let's understand how we do the cosyntropin test. So there are two varieties of the cosentropin test that's available. One is the 250 microgram cosentropin test, and the other one is the 1 microgram cosentropin test. So what are these two tests? So this is a study which compares the low dose. Low dose is 1 microgram and high dose is 250 microgram cosentropin test in those patients who had pituitary disease. All right. So these circles are the 1 microgram test and the boxes are the 250 microgram test. You can see that with the 1 microgram test, there is a rapid increase in cortisol in response to injection. It has to be done intravenously only, whereas you can use the intramuscular route for 250 microgram test. So when you look at the 1 microgram curve, so there is a peak at 30 minutes which starts reducing by the time it is 1 hour. Whereas when you give the 250 microgram cosentropin, so you have a level which is almost similar for both the tests at 30 minutes, and this level increases further at 1 hour. So it's a pharmacologically more robust test, the 250 microgram test, when compared to 1 microgram test. But many people consider the 1 microgram cosentropin test to be more sensitive. That is, it does not miss milder cases of adrenal insufficiency. So, this is some background about the testing that we have for diagnosis of adrenal insufficiency. So, this is a publication of mine about the 1 microgram cosentropin test. We derived the normative values in normal subjects. So, we defined the normative values as plus or minus 2.5 SD, and then we derived it for our institution's assay. So what we found was that the 95th percentile response, that is 95% of people who were normal and did not use any form of inhaled corticosteroid, or they had no risk factor for adrenal insufficiency, apparently normal individuals. So for them, the cortisol levels reached up to 20 microgram per deciliter, though there was a wider range. So there were patients, who measured as much as 14 microgram per deciliter, though there were only one or two. So when this is the normative value that came out of my own research, actually. But worldwide, if you look at uh, if you don't have normative data for your institution or for your assay methodology, you can use anything between 18 to 20 microgram per deciliter at 60 minutes, and you must use the 250 microgram cosentropin test. So that's the best way to diagnose adrenal insufficiency currently. So in India, we do not have the cosentropin available. So what can be used instead? So there are published data with acton prolongatum. Acton prolongatum is nothing but porcine sequence ACTH. So 25 units. 25 units. How do we draw 25 units of acton prolongatum? We do get a multi-dose vial of acton prolongatum. So you need to draw 16 units using a U40 syringe and use that. And this particular seminal work shows that the post ACTH cortisol is comparable with cosentropin. So one set of bubbles represent cosentropin, another set of bubbles represent acton prolongatum. You can see that the values are comparable. So in the absence of cosentropin, you can use acton prolongatum, and we do use acton prolongatum for our diagnosis. So, in those where there is established adrenal insufficiency, especially if you're suspecting strongly primary adrenal insufficiency, the next investigation, what we need to get is a CT of the abdomen. So, plain CT of the abdomen also delineates the adrenal glands very nicely. So, in this picture, you can see that both the adrenal glands are enlarged actually. So, I'll point them out to you. So, these are the adrenal glands. Okay. So, when tuberculosis is diagnosed elsewhere in the body, for example, if the patient already has active pulmonary tuberculosis or active pleural tuberculosis, we don't need to do a test to identify whether the adrenal gland involvement is tuberculous or not. But in the absence of any other involvement, CT guided FNAC is uh, required if there is only adrenal involvement, if there is no other external tuberculous involvement. So it's very important that we examine the patient very critically and look for tuberculosis elsewhere in the body. If we're able to find tuberculosis elsewhere in the body, it obviates a need for doing a CT guided FNAC, again, a invasive procedure. On another important note, uh, what we often miss in our practice is adrenal crisis. So, uh, many papers of late in the last 1 or 2 years have come out which look at adrenal insufficiency prevalence in those who are diagnosed with adrenal insufficiency. So, mind you, these are not new patients, these are not patients where we don't know the diagnosis. These are patients who have diagnosed adrenal insufficiency, they are on replacement. So even in this patient population, over a period of year, if you follow up 100 patients, 4 to 8 patients get diagnosed with adrenal crisis. So what is the trigger for all these things? So gastroenteritis is a trigger, infectious disease is a trigger. And also you need to note that the adrenal insufficiency or adrenal crisis per se has got a mortality rate of 1 to 5%. So in the elderly, those who are having adrenal insufficiency, young children, etc., it may be even more uh, fatal. So we need to educate our patients regarding the possibility of adrenal insufficiency. This is not an insignificant risk. So 4 to 8 per 100 is a real risk for our patients with adrenal insufficiency. So we need to make sure that they have some kind of personal identifier. We need to give them written instructions on what to do during sick days. So typically they double the dose of steroids during any mild stress. For example, I ask my patients with adrenal insufficiency to increase their steroid dose even when they have examinations and other stressful social occasions also, because then in the normal course of events the adrenal gland produces more cortisol in the presence of any stress, even if it be emotional stress. So we need to educate our patients to recognize these triggers for adrenal crisis and make sure that they up the dose of the replacement steroids and self-manage themselves better so that we can prevent these adrenal crises. So, in conclusion, I'll say that the presentation of adrenal insufficiency can be very confusing. So, it can get glossed over because of concurrent other problems. So, adrenal stimulation test, we can use even acton prolongatum. It's a gold standard for diagnosis. A value of more than 18 or 20 microgram per deciliter indicates that there is no adrenal insufficiency. A value below this indicates that there is adrenal insufficiency. ACTH will help in differential diagnosis of primary versus secondary adrenal insufficiency. Adrenal crises are common despite a prior diagnosis of adrenal insufficiency. So, patient education and having the patient develop strategies to self manage is very important. Thank you.